Hello, I'm Sandra Kaplan, and I'm here to provide a brief training video on the use of the CAT-EI, an instructional video for the APTA Critical Appraisal Tool for Experimental Interventions. In this training video, we'll review the sections of the CAT-EI and review a completed CAT-EI for one sample article illustrating where the information was found. Hopefully this will help increase your comfort with the CAT-EI tool and the appraisal skills prior to reliability testing as a volunteer for a clinical practice guideline. Before continuing this video, you should watch the overall CAT-EI introductory video available on YouTube at the following URL. In addition, you should download a copy of Taylor's article on progressive resistance training and mobility-related function in young people with cerebral palsy from Developmental Medicine and Child Neurology. I've given you the DOI number, and that link could take you directly to the article. Please read the article first, and then try to score the CAT-EI using the PDF in the link following, which is a link to the critical appraisal tool. Once you've read the article and you've scored it the best you can, then you should continue with the rest of the video to see whether your answers match the ones that I'm providing. I will tell you in advance that while there are many outcome measures in the Taylor article, this presentation focuses on walking distance, the timed up and down stairs, and the functional assessment questionnaire. So if you look at those three measures in your review, then you'll be able to match them to my answers. So just a quick overview of the CAT-EI. This is somewhat a review of that introductory video that I referred you to earlier. On page 1, you have a history of the CAT-EI development that APTA undertook. On pages 2 and 3 are the scoring instructions. So if you're not sure how to score a yes or a no or a not applicable, go back to the numbered item on pages 2 or 3, and that's where it'll help you determine whether you should score a yes, no, or not applicable. Page 4 is the beginning of the actual tool. At the top is an area for the title and the study type. It has part A, which is the study purpose, its setting, including the PCAT question, components, and IRB statement. It also has part B, which is the beginning of the actual risk of bias assessment. And it's focused on the design measures in those first 12 questions. Page 5 at the top continues with questions 13 through 20, but these are specific to the outcomes of interest. And you'll see at the very top of the page, you can identify up to 5 specific outcomes and the actual tools that are used. And then those numbered outcomes should align with your numbered columns in your assessment. Below that, you have the opportunity then for each outcome of interest to determine the overall quality rating for that outcome of interest based on both the design measures in questions 1 through 12 and the outcome measures in questions 13 through 20. Part C is an opportunity for you to describe the impact of that study result. So at the top of page 4, this is the critical appraisal tool for experimental intervention and a place for your responses. At the very top, you can circle why you included this particular study in a cluster of studies that you might be reviewing. So is this a randomized controlled trial or a trial with a comparison group? Is it quasi-experimental, no randomization and no true control group? Or is it single subject design with a minimum of an A and a B phase, or some other experimental study design? It would not apply to non-experimental studies. You see below that you have fields to put the title of the study, who the authors are, the journal, volume, and year, and a place for your name as the reviewer and the date that you reviewed it. So for the Taylor article, this is a randomized clinical trial with comparison group. It has the title, the authors, the journal, the year, and the volume, and then myself as reviewer. The next section underneath that is a chance for you to tease out the focus of the article. So the primary purpose can be divided into this PCAT formation. So who's involved, what population is included, what are the intervention methods? So it's individualized PREs, and you can even put in something about the dosage and the treatment frequency. What's it compared to? What are the outcomes? So we took the 6-minute walk test, the FAQ, and the time up and down stairs. And what are the time frames? They had a baseline measures at 12 weeks and 24 weeks. It's in a community setting, and the geographic setting, this is a study that was conducted in Australia. In the last portion here, did the study author indicate compliance with IRB regulations? And they did make a statement in the study. So all of this information helps if you're teaching critical appraisal to folks who are not experienced with it, perhaps students, because this is where they can tease apart the purpose of the study and a little bit about the context. The actual risk of bias assessment starts with section B. It's also on the first, on page 4. And these are the answers with the page numbers of where they've been found. I'm going to go through each of these in successive slides. So for items B1, 2, and 3, are inclusion criteria for the subjects specifically described? Are there exclusion criteria? And do the recruitment methods reasonably attempt to minimize bias? And in their participants section, they describe how they recruited the children and who was to be included and who was to be excluded. And they're pretty clear about what those criteria are. B4 was an a priori power analysis used to determine the minimal sample size. And they actually did do a sample size calculation based on an observed effect size reported for the 6-minute walk test. And so they determined that to achieve 80% power at 95% confidence interval, a sample size of 31 participants in each group was required. Keep that in mind because we'll look at whether they met that sample size later on. Questions B5 and 6 were the participants randomly assigned to intervention groups, and was allocation to the treatment group concealed? And in both cases, yes. Under their procedure section, they talk about the concealment and the allocation process, rather, a block allocation using pieces of paper, right, drawn from a sealed container. And where they the allocation section, right? Assessments were completed by an assessor blinded to the group allocation. So we kept those treatment groups concealed. For B7, was there a control group? And they describe usual care, which we don't necessarily consider a true control group. A true control group would get no care at all for the time of the study. Usual care would need to be described very clearly in terms of the type and dosage to allow for more clear comparisons. So while they were allocated to the control group, continued with usual care during the intervention period. In that time, they could continue their usual recreation and physical therapy. And these did not include progressive resistive training, but we don't know what else it did include. Were the subjects blinded to the treatment group? You would know if you were getting usual care, so they couldn't be blinded. And the interventions for all the groups described in sufficient detail. Again, the usual care is not described in enough detail. Was adherence to the study protocol described? So in the results section, they describe their adherence and the fact that participants did not deviate from the groups. So they completed a mean of 21 of their 24 scheduled training sessions. Was the presence or absence of adverse events described? And under safety and adverse events, they described some of the reasons for missing the training sessions, a little bit of muscle soreness that disappeared after a few days, and one person had a minor calf strain and another a little bit of plantar fasciitis, but these were accommodated in their programs. So they did do a description. And our conflicts of interest managed to enhance confidence. And at the end of the article, in their acknowledgements, they do identify that they were funded by a grant. So they have at least identified a potential source of conflict of interest or funding that may have an interest in the study. It doesn't say specifically that the funding source did not influence the publication, but generally this type of funding would not. So let's talk a little bit about outcome measure elements. Most of you may be familiar with the Center for Evidence-Based Medicine's original levels of evidence table. It's organized by therapeutic interventions, prognostic, diagnostic, economic analysis columns. And levels of evidence were assigned based on, in the intervention category, purely on the type of design. A systematic review with RCTs or an individual RCT would be up at the 1 level. A systematic review of cohort studies would be at the level 2, or an individual cohort study would be a 2B. And outcomes research, where there is no control group, it's just a pre-test, post-test, was also considered level 2C. Case control studies were level 3, and it goes on down. The table doesn't account for the quality of the outcome measures that might have been used in those studies. So while you might have an RCT, it's a rigorous design, but if they used outcome measures that didn't have reliability and validity established on them, then you would need to drop the level down, because the quality of the outcome measures themselves, the quality of the data collected, is going to be, you should have less confidence in that if validity and reliability haven't been established. The CAT-EI teases apart this notion of research design from the outcome measures and allows you to assess the quality of a particular outcome measure within the design of the study. So part B, questions 1 through 12, look at that overall design. Was there blinding? Was there allocation? Did they do a power analysis to set up the design? But questions 13 through 20 look more at the rigor of the outcome measurement itself. We would hope that those studies with reliable and valid outcome measures would score higher than those with untested measures, and that at least one measure is typical of most sort of basic science studies. There may be one specific outcome of a pharmacological study, but in rehab studies, we know we typically have more than one outcome measure. Often there are 3 or 4, one for every ICF domain, plus a quality of life measure, maybe a perceived exertion measure. And so when we have so many measures in a study, we need to look at each of those measures individually. And that's why the earlier Center for Evidence-Based Medicine Levels of Evidence, which is based on medical studies and pharmacological studies with a very clear dichotomous outcome, didn't maybe need to account for multiple outcome measures. In rehab, we need to think about multiple outcome measures and separately assessing each of those. Therefore, a well-conducted study with both strong and weak outcome measures needs to be graded differently based on the outcome measure strength, even within the same design. So this is just an illustration of how we might want to think about clustering levels of evidence when we have multiple articles. This was the old way. Based on the design alone, we would give it a level of evidence. But now we need to think about taking our outcome measure and almost threading through multiple articles to see what the quality of that one outcome measure is in different studies. And then the second outcome measure through those different studies. And then the third. And if one of these is a weaker outcome measure, poor reliability, or maybe no established reliability, then it's going to get a lower level of evidence than we would have given it just based on the design of the study alone. This is a really important point. So when we look at the second portion of the outcome measures, we might see that there are differences. So the 3 outcome measures that we are looking at in this study are the walking distance, up and down stairs, and perceptions. Walking distance was using the 6-minute walk test. Up and down stairs was a timed protocol. And the perceptions was the functional assessment questionnaire, or the FAQ. And so each one of these is assigned to each of the outcomes. So outcome 1 on walking distance is going to be assessed in column 1. Up and down the stairs will be assessed in column 2. And the FAQ will be assessed in column 3. So for questions 13 and 14 about established validity and reliability, right? For outcome 1 on walking distance, we can answer yes to both of those because the 6-minute walk test has been shown to be highly reliable, right? They have reliability as a citation, and we could go to the 6-minute walk test for children with cerebral palsy, Mara's study that established that reliability and talked about the validity of this walking test as a test of walking. Right? In addition, they talked about its responsiveness to improvement and strengthening through Anderson's study. And that gives it additional validity that you can expect a change after strengthening. And this is a study that looked at changes in, using a strengthening intervention to see if they would get changes. When we look at the up and down stairs, right, we have to circle no for each of these, that even though they provide a reference, right, the secondary measures of mobility function were assessed objectively and comprised self-selected walking speed, a timed stairs test assessing the ability to go up and down 3 stairs, and they give you a citation. I have to go back and look at that citation. The citation is an actual study that used the up and down stairs, but the reference, Dodd's study, does not establish reliability of the up and down stair protocol, nor do they cite a source for reliability or validity. So while they are giving credit for perhaps adopting a protocol that someone else developed, there's still no reliability about that test. And we could say it's probably valid because on the surface, face validity, to look at how much time it takes you to go up and down stairs. But they only chose 3 stairs. And maybe that isn't actually a representation of what is functional in terms of movement up and down stairs. So I've selected no for both of those. Could be argued that maybe established validity might be a yes. And this is where some discussion within a group might happen. For our third measure, the FAQ in column 3, again, we can answer yes for both of those. Here they give the FAQ, a 10-level report of the level that best describes typical walking ability, and they give the citation. Novacek's article on reliability and the validity of the Gillette Functional Assessment Questionnaire as an outcome measure establishes both. So here by reference, they've given a citation, right, to justify the reliability and validity. That's different, though, to say a test is reliable, but are the testers in this particular study, have they established reliability, especially if there's more than one person doing the measures? Are they reliable within themselves and with the other testers? So was reliability level of the testers reported for each outcome of interest? And we have to answer no for that. Were the testers and data collectors blinded to the treatment groups? Excuse me. We can answer yes to that. And they describe that on page 807 that the assessments were completed in a hospital gate lab by an assessor blinded to group allocation. So for the rest of this, we're going to talk about the walking distance as the key outcome measure. Was intention to treat followed? And they describe on page 808 that the intention to treat principle was applied with available data of all participants who were allocated and commenced their program included in analyses. So they included everybody that they could, and the people were kept in their allocated groups, meaning there was no crossover. Did the sample size meet power requirements for the outcome of interest? And here we have to answer no. They said of the 50 or 49 participants, 24 were allocated to the progressive resistance training intervention and 25 to the control group. But remember that on B4 in our design, when they did their a priori power analysis, they established that they needed 31 per group, but they only had 24 and 25. So the study is underpowered. Were the groups equivalent at baseline? And here you would need to look at tables 2 and 3 because they describe the data at baseline, week 0, right, at the beginning of this study. And they have for each of the measures what the experimental group and the control group scored. And you'll see that none of these have any indication that there was any significant difference between the groups. So yes, the study groups are equivalent at baseline. For B20 is the effect size and precision reported for each outcome of interest. And at week 12 and at week 24, right, we can see that, yes, they're including the effect size in tables 2 and 3, right? And in these cases, we can see they've got a little asterisk here that there were some significant differences. So for the walking distance and the FAQ, all of these responses would be the same. But remember that the stair walking, right? We had to answer no for the validity and reliability questions. So there's going to be a little bit of a difference there. So when we take the tally from the first page, where we had 9 out of 12 yeses, right? And we add that to the tally for each of the columns. So in our first column, out of the 8 possible yeses, there were 6, right? And if you add the 6 to the 9 from the first page, right, you get 15 out of 20 potential answers. But for our up and down stairs, our second outcome measure 2, remember that there was no reliability and validity established in the literature or in any way. And so they're 2 points lower. And so the 4 plus 8 and the 9 over the 12 gets you to 13 over 20 possible yeses. So we have a slight difference, right? Walking distance as an outcome within this study has about 75% of the items reported as having been done, whereas our score for or our tally for the up and down stairs is a little bit lower at 13 out of 20. So we're always thinking about the first tally from page 1 and adding that to the outcome tally of the outcome of interest in order to get a particular outcome total. And from there, we can look at this quality rating, right? So for outcome 1, it's an acceptable quality. 75% of the items were reported, maybe based on the kind of systematic review you're doing, and based specifically on what items were not achieved or rated as yes, you might decide to downgrade it. It's possible that you might consider this a low quality study because it was underpowered. And if that's a criteria that you're going to use across all studies, then it would be dropping the quality, right? In this case, it probably, with outcome 2, for the time to up and down stairs, right? We might drop it because not only was it underpowered, but we didn't have any reliability or validity established for using 3 steps as an indicator of the ability to go up and down stairs. This is all based on discussion, though. And this is where the guideline teams will take your scoring of part B, questions 1 through 12, and then questions 13 through 20, and make a decision here about whether they feel this study meets the quality that they want to include in the systematic review. And if they do include it, at what level of evidence they will assign it. I hope you can appreciate, though, the importance of pulling apart the outcome measures from the design in order to compare the different levels of evidence that might be assigned within the same study. So we can no longer just assign the study a level of evidence. We really have to do the study with it and the outcome within it. So in summary, all articles may have missing items, and it may be that those items, were done and just not reported because there are page limits and word limits that force authors to choose to omit some items sometimes. Some of the missing items might be more important than others, depending on the design of the study. If they didn't do an a priori power analysis, but they did a post hoc analysis of power and established that they had enough of a sample size, that might balance and give you greater confidence that the results really are different, right? A pilot or proof of concept article may be underpowered, but demonstrates some very strong post-test changes that you may still include in a systematic review. But again, it gives you a way to discuss that study and put some caveats around how much confidence we should have in the findings and the importance of replication with a fully powered study. So the CAT-EI allows you as an appraiser to separately evaluate study design from outcome measurement qualities, and both contribute to our confidence in the results of the study. So I thank you for listening. I hope that by taking you through the Taylor article, you can appreciate how to use the CAT-EI with a little bit more confidence. And we all know that with critical appraisal, the more frequently you do this, the easier it gets and the more confidence you develop that your judgments about what is in an article and what is not stated in an article is more valid and more accurate. So good luck with critical appraisals.